We're at Wake Forest University, the home of the Bowman Gray Medical Center, intending to explore in several programs the constituent pieces of the healthcare crisis. Today we will examine the question of primary care. Do we need the Clinton proposal in order to guarantee the primary care that all America depends on? Stay tuned.
This program is a Warren Steibel production in association with South Carolina ETV. Funding for Firing Line is made possible by a major grant from the John M. Olin Foundation, Incorporated. Additional support is provided by the Annenberg Foundation, the Laurel Foundation, and the Friends of Firing Line.
It has been suggested at this first program at the Bowman Gray Medical Center here at Wake Forest University, and I'm taken by that suggestion, that one of our guests should state the agenda for this firing line. I shall introduce him last and note now the other participants. They include Miss Inga Collins, who is training to be a medical specialist, and Dr. Jeffrey Davis, an intern, who is training to be a primary care internist. Dr. Marjorie Bowman is with the Department of Family and Community Medicine here at Wake Forest, and her colleague and our agenda setter in this program, Are We Neglecting Primary Care?, is Dr. Richard Daneway. He's the Dean of the Bowman Gray School of Medicine, a graduate of Colgate and of the University of Pennsylvania. Dr. Daneway, what is it in the matter of primary care that you wish us to probe?
Well, the question is the American medical education system neglecting the preparation of young people for entry into the primary care disciplines? And I would say that nationally that's a mixed bag. Here at Bowman Gray, we put a lot of emphasis on exposing our students to primary care education, but fewer of our graduates than I would desire go into family medicine, general internal medicine, pediatrics, or OB/GYN.
Why?
That is a question that I think needs to be determined. What my choice is not necessarily, nor should it necessarily be identical with the free choice of students. And the Clinton's healthcare reform plan raises some fundamental basic questions about their choices of entering into specialties. If the Clinton healthcare plan is passed in 1994, by 1998, entering medical students will have been severely restricted in their choice of specialties in the United States. By law, 55% of all graduates will have to go into the primary care disciplines. Now, how is this going to be accomplished? There would be a National Council on Graduate Medical Education that would determine specialties in excess of what they determine to be national need and cut them by 50%. Now, how do you enforce that? The allocation would be made, and any program or hospital that accepts a trainee beyond the allocation would lose all of its funding for graduate medical education.
You mean they just turn around and say, sorry, you can't study proctology?
That's correct. If it's not approved at the... Well, I don't blame them for saying that.
But now, I saw some figures recently, which there's been an enormous drop in the United States in people who go in for general practice, and it's now hovering around the 40% figure, whereas in other Western countries it's 60%. Now, how do you account for that? What's going on?
Well, I think modern American medicine has grown up around the need to specialize and around technology, but we're seeing among the medical students today, and you'll hear some of that from Inga Collins and Jeff Davis, a change in attitude. Private sector initiated managed care is sweeping this country, and there is a recognition among medical students that there is greater public acceptance for the primary care disciplines, their role in the control of costs, and in the continuum of care. And I think we're seeing right now more people coming in. The question is whether we need some kind of national law that abridges academic freedom and individual choice and coerces people into a decision that is surely, whether it's educational or professional in its outcome, is going to occur on its own.
Well, you raise a very interesting, among other things, a philosophical question. Are you aware, Dr. Bowman, that the United Nations Covenant on Human Rights, as passed in 1947, considers it a human right to have the job of your choice? That kind of amused me as an undergraduate. If everybody wanted to be a photographer, then presumably, if we believe in human rights, we'd all have to be photographed a lot more than we now are. But what is the traditional means by which medicine says we don't need any more liver specialists? We got enough. Is it communicated through the market, economic signals?
Well, currently there is no regulation of the numbers in the specialties, and it is determined through accreditation what numbers can exist in programs. But the National Accreditation Council does not determine how many should be in a specialty. So there is no setting of the numbers. And it has been, therefore, you could say, market-driven. And the market has been that those who enter many of the specialties earn far more than family medicine, for example. And that difference has grown over the years. And as it has grown, we also have had fewer who've elected to do that.
Now Marjorie and I disagree on one thing. She's emphasized the cost difference, the income differential between the generalist and the specialist. And I think there are other factors.
I'm sure
that's certainly an important one.
Correct me on this. I've always assumed that a specialist decides to be a specialist for one of two reasons, or partly for each. Number one, the income tends to be better for a specialist than for generalists. That's not incorrect, is it?
That's correct.
And number two, if you absorb by the scientific challenge of coming up with fresh therapeutical devices or scientific devices to concentrate on one particular ailment is a natural thing to do. Have I missed one?
Well, for example, I originally was planning to do family medicine, and recently changed my mind to go into obstetrics and gynecology. Well, the main reason being, after going through my third year of medical school, I realized there are certain areas of medicine that I enjoy more than others, and that area of medicine was surgery. There are several areas of surgery, but part of obstetrics and gynecology is you get the joy being in the operating room. The other benefit of obstetrics and gynecology is that you're able to have a certain amount of primary care, following women over a long period of time, and for many healthy women, their OBGYN is their only doctor that they see.
It is an affinity for that branch of medicine, which is as understandable as somebody wanting to be a violinist rather than a flutist, right? It's an affinity. But once again, the market picture has to have some bearing on the question, since there are more violinists than there are flutists, and people would take that datum into account in deciding which direction to travel. What was it that caused you to go in the other direction?
I think you're right about the concept of proclivity to go into something. In many senses, I feel I'm a born internist, and what makes a person an internist, what makes a person want to be a surgeon, and how do they wind their way through medical school and find those things. For me, being an internist meant a variety of things, one of which was intellectual satisfaction in diagnosis and problem solving, which is one of the traditional hallmarks of internal medicine. But how I found that was in medical school, being exposed to a group of people who practice medicine. I had mentors and role models very early on, and I can't emphasize how I think important that is for medical students, what exposure they get to people who they see practicing something that they're happy doing. Surgeons who are happily practicing their trade for many years, or internists or primary care practitioners who are in the community seeing patients and showing medical students at an early stage that this is a viable, exciting, interesting thing that I do. You could do this too.
Well, in your experience with your fellow students, what have you detected is the primary drive away from general medicine? Is it the kind of thing that Ms. Collins talks about, a fascination with this or that?
I think there's an absence of role models of people who are happy doing it in the medical school setting, meaning that general internists have always practiced primary care. They've been doing that as long as internal medicine has been a specialty for the past 30 years. Yet I think that the tradition in past years in the university setting has one, as Dr. Janeway says, been a trend towards specialization. That's not to say general internists aren't there, but I think that proportionately the role models tend to be more specialized.
How about that, Dr. Janeway? Are you old enough to remember Dr. Kildare? Probably not, right?
Aren't you nice? Yes.
Well, in my youth, Dr. Kildare was the hero in every third movie. And some stricken person would come in, he'd look at him and say, "Bring me an XYZ." And he was marvel at how he intuits what is required to cure this lady, to keep her from dying. Now, that kind of a role model, has that disappeared because the camera is focusing on the miracle cure in a particular specialty? Are they getting all the publicity so that the role model of the general practitioner diminishes?
Well, there is a kind of disease or specialty of the month that comes on. I think one of the things that perhaps in medicine we have not done as well as we ought to is to get rid of the notion that there is perfection in medicine, and we've been all too ready to accept it. But in answer to your question, I think that the character and the capability in American medicine has moved away from the picture of the kindly old man who really had less to do. I'm talking about Dr. Gillespie. You can tell how far I go back. But who really had little else to do than be caring and compassionate. And to the extent that there has been a loss of that, I decry it. But it has gone more to a knowledge-based and a capability that is out there. It's one of the reasons people don't make house calls. But the young people I see in medicine are wonderful. And I think that we're noticing, and whether it's a recognition of the market, and Marge and Inge and Jeff can talk about this probably closer than I, there is much more interest now in going into the generalist physician disciplines. And I think you can reflect that in applications to your residency.
Is that reflected in the figures? Is it coming up from that 40%?
Well, over the years, there's been a decline in the numbers who've been entering the primary care disciplines.
Yeah.
And last year, we saw a blip upwards. And I think this year that, again, there will be more. And I think there are a variety of factors, part of which Dr. Janeway was talking about earlier. The marketplace is changing. There's more emphasis on family medicine, general internal medicine, pediatrics through managed care. As managed care expands, as we're talking about health care reform, which includes prevention, one of the areas that primary care physicians have done much more of, those recognitions and what goes with it encourages more individuals to enter the field.
Well, now, what is it that caused the Clinton epiphany on the subject, that the federal government had to get in the act and regulate the number of people? What was the crisis that he directly faced?
I think
I'd love to hear your answer to that.
Well, I think that between costs and access to care, and if you look at the systems of care that have developed in the United States, which tend to be managed care systems, they use far more generalist level physicians than is available out in the rest of the market.
But the question, and you and I have discussed this in the past, is whether you need some kind of coercive legislation that regulates and determines what they're going to allocate spots based on the National Council on Graduate Medical Education's estimate of the relevance of the curriculum to the practice of that specialty. Now, I mean...
And changes in the training positions, the number of training positions, actually won't have a very immediate effect. If we really need immediate changes in the number of positions in graduate medical education, given that a physician practices for 30 years and we have many physicians out there, is a long-term solution and will not actually make a tremendous difference in the short term.
If you had 50% of all the residency training physicians in primary care as of 1995, it would be the year 2040 before there was a 50% representation in the medical profession of people in the primary care system.
I knew it was behind, but I thought it was only behind to 40%.
It's about 37%.
It would take that long to build back up to 50%.
That's correct.
And so there are alternative measures rather than having such heavy-handed regulatory things.
What are those?
Well, people who have been in specialties with managed care coming along, many of them, I believe, will retrain in family medicine. And indeed, the more appropriate use of physician assistants and nurse practitioners as part of the team. The younger people are more attuned to this and I think can make some very useful suggestions about that.
How tough is it so suppose you're 40 years old and have been practicing as a heart specialist or whatever, and you decide to retrain. Do you have to go back to school?
You would go to a training program.
I will comment that there are a couple of the HMOs that are starting retraining programs for their own physicians. There are no national level retraining programs existing now, but as there is market pressure, there are certain types of subspecialists, one might call them, that can more easily learn primary care types of attitudes and knowledge than others. A neurosurgeon who's always been a neurosurgeon, I perceive as having more difficulty becoming a primary care physician than an infectious disease specialist, for example.
Never get a neurosurgeon to agree with you on that, of course.
Yeah, a neurosurgeon doesn't know what to do about measles, does he? I suppose.
Correct.
Yeah. Well, now, has the movement of which Mr. Clinton is the incarnation been around for a long time? Have the medical schools and medical students sensed a problem in primary care? And if so, what was the solution that was generally espoused?
I believe there has been a general recognition among the educational leadership of medical schools that students needed more exposure to primary care and needed to look at their curriculums very carefully. When the Robert Wood Johnson Foundation came out with a program for people competitively to apply to alter their curriculum to more effectively to represent primary care, 70% of the American medical schools sent in proposals. So there's obviously a great deal of interest. I think it takes the change in the external world. Medical students are very smart, and they see, I think, beginning in the last couple of years, a change in the marketplace, where the opportunities are, where there are some exciting things to do, and the question, once again, I raise, I know of no other federal legislation that inhibits free choice of career path within a professional discipline. Not in law, medicine, not in law, dentistry, engineering, certainly not the ministry.
Well, to what extent is it fair to think of medicine as a calling? For instance, take teachers. That might be an analog. If you have a situation in which there is no teacher in this 100-square-mile area of Nevada, people like to think that a teacher will say, okay, I'll go, because I feel the calling to teach. And even though obviously teachers have economic responsibilities, family responsibilities, so do doctors, but is there a lively sense among people who are studying medicine that they're engaged in a calling?
I believe so, definitely, because If I were going into medicine because I solely wanted to make money,
Yeah.
I'd be in serious trouble. I would have dropped out the first year.
Why?
Because there's much to much of a time investment involved. You're giving up a lot of free time. Let's say your fellow graduates from college, you know, they're out in the world, they're making money already on their own. You lose a lot of your freedom. You lose a lot of your social freedom as a medical student. And there's a lot of, I guess, time lost, I guess, in the workforce.
Wait,
I don't. There's
are
no
you-
way
are
I
you saying-
could go
you're
into
saying-
medicine if I didn't have such a desire to be in the field of medicine. If I was doing it.
Are you saying that a brain surgeon has to put in more hours in order to become a brain surgeon than an internist does?
Yeah, oh, definitely.
Why?
Well, I think it's the specialty of the training and the procedures you have to learn. Yeah, it's an art, and there are certain areas of medicine that take, you know, far more training.
And how habitually do they do that? You become an MD and that's to stay longer as an intern if you want to be a brain surgeon?
Specialization, whether it's in surgery or medicine, typically builds on a basis of generalism. So whether you're going into a surgical subspecialty or an internal medicine subspecialty, typically you will be go to a 4 or 6 year medical school, go on to an internship of some general sort, maybe more training of 2 or 3 years in general surgery or general medicine, as the case is in my point.
Wait, is there a basic
training.
curriculum that all doctors go through?
Oh, yeah,
Medical
it's called
school.
medical school.
Yeah, right.
We had unanimity on that one.
And then there's residency, and that's where the variation.
So when you talk about retraining, you mean to go back and learn something you already learned but have forgotten?
Being a physician is a lifelong student in any event. We are always learning and doing continuing medical education. It would be what would be the focus of the education, and how much would be required to do that is what would be retraining.
Let me put that in perspective. Jeff is going to have 3 years, has just finished 3 years after medical school in a general internal medicine residency. And everybody who is in the subspecialties of medicine, whether it's cardiology or, you know, name it, have also been through that 3 years. So retraining that group of people is a very sensible and logical thing.
Is that contemplated in the Clinton program? Retraining in order to beef up the number of internists?
No, I'm not aware of that as a portion of the plan.
But would this necessarily follow? Given what you just said, that would take them to the year 240 before you build up this...
And whether that's a significant year or not, I don't know. The question is whether forcing it to 50% is really a necessity. Or
Will
whether...
it have the intended results it's hoping for?
Right.
In fact, there are other incentives that are in the health care reform that really will encourage primary care.
Right.
And the incentives that are built in on that end will probably make more difference, in my opinion, than forcing the training positions at this time.
Well, would you favor extending the jurisdiction and the authority of, say, of nurses so that some of the elementary needs now done by doctors in primary care could be given to somebody else, like sort of paramed types?
I think that team practice is currently the norm and will continue to expand. And the team who helps take care of the patient does include nurses. I do not think that nurses can fulfill the same role as primary care physicians at this point. Can they be a part of a team that helps take care of patients? Nurses in my office do a lot of things that help patients on an everyday basis. But I think it is part of a team function to take care of the individual and the family or a set of patients. And in that way, nurses have a major role.
Well, to what extent are you victimized by certain tribal taboos? You know, for some things you have to have a lawyer, quote unquote lawyer, even though somebody other than a lawyer is perfectly competent to discharge that particular function. Are there a number of things currently being done by MDs that could be done by other than MDs?
I think that's the case, but overall coordination of care, it's partially a matter of efficiency and what level of training is required for full efficiency.
Yeah.
And you want a team practice that can take care of most of the needs of patients in a coordinated fashion.
But you would agree, Marjorie, wouldn't you, that in an extended situation, say in rural health care and stuff like that, that a nurse practitioner or a physician assistant, under the supervision of a physician, there are many things that they can do appropriately.
That's correct. There are many
like
things they
midwife
can
or
do.
baby.
And if I think that in conjunction with the physician, that's why I was talking about the team care, I think it can work very well. I don't think independent practice of the same level as primary care physicians do is currently possible. If nurses got more training, I would say yes, but the level of training of nurses at this time is inadequate to fully function in that role.
Well, we only have 1 minute left. Let me ask Dr. Davis whether that aspect of the Clinton program is one that disturbs you as somebody who's just about to embark in Burlington, Vermont on general practice.
I hate to say this, which aspect are you asking for?
Yeah, the aspect of insisting on increasing the number of primary care doctors.
It's difficult to say. Again, the issue of coercion is one that we would, I think, all like to avoid in terms of finding a way to provide primary care to the people who need it. I think it really depends on your fundamental view, and Mr. Clinton, in the address I heard last night, had a bottom line, which was universal access and care for all those who don't have health care. And the big issue is how to go about providing that, and it seems to be a great controversy.
Thank you, Dr. Davis, Ms. Collins, Dr. Baumann, Dr. Daneway, ladies and gentlemen of Bowman Gray Medical Center at Wake Forest. Thank you.
Next week on the second in a four-part mini-series that puts health care on the firing line, host William F. Buckley Jr. asks Dr. Ward Curad, Charles Sanders, and Richard Janeway if medical costs are controllable. This program was a Warren Steibel production in association with South Carolina ETV. Funding for Firing Line was made possible by a major grant from the John M. Olin Foundation, Incorporated. Additional support was provided by the Annenberg Foundation, the Laurel Foundation, and the Friends of Firing Line.